Hello and welcome to the Alabama Public Health Training Network. Glad you could join us for this program, Developing Alabama's System of Services and Resources for Children with Autism, Lessons Learned and Taught. Our objectives today are to describe the Autism and Developmental Disabilities Monitoring Network, data and applications for system and resource development for individuals with autism spectrum disorders, outline the Alabama Autism Interagency Coordinating Council's strategic plan and leadership for regional centers, discuss the roles of public health surveillance, policy and strategic planning in development of a system of care for individuals with autism in Alabama, and to compare the autism systems in Alabama and South Carolina. If you have a question about anything being discussed today, please call or email our faculty presenter during the live broadcast. Our 800 number and email address are up on the screen now and will appear again throughout the program. Also, the handouts, sign-in sheet, and evaluation for this program are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for both nurses and social workers for this program. The ADPH is an approved provider of continuing nursing education by the Alabama State Nurses Association. The association is an accredited approver of continuing nurses education by the American Nurses Credentialing Center's Commission on Accreditation. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. Instructions on how to do this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, CE credit will only be awarded for 2 years from today's date, which is May 7, 2014. There is no financial relationship between the planners of this program and the speakers. There is also no commercial support for this program. ADPH does not endorse any product that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of products. Today's program is produced by the Alabama Public Health Training Center. If you'd like more information about the center, you can visit their webpage listed on your screen. Let's meet today's faculty presenters. With us today, we have Martha Wingate, Associate Professor at the University of Alabama at Birmingham, Jane Charles, Professor of Pediatrics at the Medical University of South Carolina, and Anna McConnell, Alabama State Autism Director. Welcome to you all. Jane, Martha, I understand that there's a lot of progress being made in Alabama in developing partnerships to serve those with autism, and I'm looking really forward to what the panel has to share with us about those programs and the progress and planning and impact of those things both at the state and national level. Will you take this opportunity to introduce the rest of the panel, please?
Absolutely, absolutely. I'm Martha Wingate. I'm at the UAB School of Public Health, and I'm the director of the Alabama Autism Surveillance Project. And so we're going to start our program and talk a little bit about the data, about what we do in terms of data collection in Alabama. And then Anna's going to talk specifically about some of the initiatives that are going on with the Interagency Council. And then Jane, our guest from South Carolina, is going to talk about sort of the progression of and some examples of where another ADDM site or ADDM state, and we'll talk about what that means in a minute, of where they've come and where they've been, and maybe some lessons that we can take from that as well. So I want to talk a little bit about our ADDM data and about autism data, and specifically about this ADDM, the Autism and Developmental Disabilities Monitoring Network specifically. And data is sometimes not very exciting to talk about, but view the data that we collect and the information that we're able to gather is really that data collection, measurement, and interpretation are really critical for making decisions related to services for children and their families. And that's really what this ultimately is about in terms of making sure that we have services in place that meet needs and the critical needs. So the Autism and Developmental Disabilities Monitoring Network, or ADDM as we'll refer to it, is a group of programs funded by CDC to estimate the number of children with autism spectrum disorder, or ASD, and other developmental disabilities in selected communities. The ADDM network sites are located in different areas of the U.S., and they all collect data using the same method. So again, same methodology, different sites across the country, and you'll see a visual of what that looks like in a minute in terms of where our sites are. And in this presentation, you're going to hear about some contextual and policy and other issues in 2 states where there are ADDM sites. So the overall goals of the ADDM network are to describe the population of children with ASD, compare how common ASD is in different areas of the country, identify changes in ASD occurrence over time, understand the impact of ASD and related conditions in select U.S. communities, and specifically, the ADDM site in Alabama is known as the Alabama Autism Surveillance Project, and we actually conduct surveillance on ASD as well as cerebral palsy. And when we say surveillance, we really mean tracking. And our goals for that specific project are to obtain as complete a count as possible of the number of children with ASD in our specific project area, provide comparable population-based ASD prevalence rates, determine whether ASD is more common in some groups of children than others, and to study whether the number of children with autism is changing over time, as well as to improve the consistency of identification of individuals with ASD. So why surveillance? We serve as the bona fide agent for the Alabama Department of Public Health in this effort, because in public health we talk a lot about surveillance and tracking. And what our goals with the surveillance is to think through that prevalence estimates can be used to plan policy, educational, and intervention services and needs for persons with ASD. So in other words, the idea in terms of counting or tracking and knowing how many people have ASDs or have been identified, that helps us with the planning process. And that ultimately helps us in terms of knowing from an educational standpoint what we need to be thinking about, from a medical standpoint what we need to be planning for and to be able to provide services. So a little bit about the history of the ADDM Network Project, or the Alabama Autism Surveillance Project. We've been funded for 2002, 4, 6, 8, 10, and 12 study years. And in the first few years, 2002 to 2008, we actually monitored the 32 northern counties of Alabama. And then for our 2010 and 12 study years, we actually monitored 9. And I'll talk a minute about why we moved from the 32 to 9. And 2004 was a little bit of a different study year in that it was even smaller in 3 counties, and that was a funding issue. And for 2010 and 2012, we actually collected in both clinical and school settings, which for us that was a very big deal in terms of being able to make that progression from just being a clinical data site to expanding to a few school systems. So the ADDM methods specifically, and this crosses across all ADDM sites, we focus on 8-year-old children, but we review records from birth to age 8. So in other words, if children in our 2010 study year, these were kids that were born in 2002, and we look at all of the records that we have, all of the information that we have. And case ascertainment, we have a wonderful group of abstractors, which you'll see their names in a few minutes, that we couldn't do this project without, actually go in and abstract data from medical and educational sources, and they review the multiple, we go through a process with our clinician reviewers of actually reviewing multiple medical and school records. And the abstractors actually go in and look for a designated list of autism triggers. So they're looking for information in records and educational sources. So understanding that an ADDM case is not necessarily a diagnosed case in the community, that it's truly a case definition based on our ADDM methodology. And as I mentioned here, that an ASD case status is determined by our clinician reviewers who are CDC trained. It's very standardized, and use a systematic application of the DSM-4 coding scheme. And we have 3 different classifications. Each child is determined to be a confirmed case, a suspected case, or a case that does not qualify. So we can see here that our ADDM sites, for the ADDM network sites, these are the states that have sites within each state. So it could be selected counties, as I've mentioned, or some other geographic area. And you can see the colors indicate what developmental disabilities, in addition to ASD, is that public health tracking is collected. So you can see here's the Alabama, the 9-county surveillance area, and we actually, as I mentioned earlier, we were originally in 32 counties and then curtailed our surveillance area to be 9, and that was really to give us a chance to go from school system to school system to connect a little bit more with those educational records, or to be able to connect with the educational data sources to get into the school system, if you will, to be able to partner with them. So over time, you can see on this chart, we have on the far left the surveillance year, and then the birth year of the children that are included in that year, and then the number of sites that were reporting at that year, and then the ADDM average prevalence, and in parentheses in the bottom of that is the actual range across the sites. And then the final column is the Alabama-specific prevalence, and this is all per 1,000 8-year-old children. And you can see that if that very bottom row in 2010, these are the latest numbers that have come out from our ADDM report, and this was the birth year of 2002. The prevalence was 14.7. That was the average ADDM prevalence, 14.7 per 1,000, or 1 in 68, as many of you are probably familiar. And then for Alabama, it was 5.7 per 1,000, or 1 in 175. And we'll talk a little bit more as we progress through this program, maybe why our numbers look a little bit different than some of our other sites. So again, the general pattern, just looking at a little bit more data, you can see that for males, it's ASD is actually much more prevalent in males than it is in females. And again, we see the same pattern across males, females, non-Hispanic white, non-Hispanic blacks, between Alabama and the ADDM average prevalence. But in Alabama, our numbers, again, are lower. So generally, we see a higher prevalence in boys and non-Hispanic whites. So I think this is an important slide for our clinicians and for folks that actually see these children and families and are working hard to engage in earlier identification. So of the children in our database that we actually have a diagnosis of ASD, and that's about 80% of the children in all the ADDM data, and about 75% of children in our 2010 Alabama specific data. So you can see that for autistic disorder, the median age is about 48 months, and it's slightly higher in Alabama at 51 months. And then for ASD PDD, 50 months and 53 months in Alabama, and then for Asperger's, 74 months for ADDM and 73 for Alabama. So we have a ways to go in terms of meeting benchmarks for identification and being in line with where we want to be in terms of getting these children identified and into services earlier. So Alabama in 2010, as I mentioned, unlike previous study years, we were able to include a few educational sites in our 2010 study year. But if you've had a chance to look at the CDC report, a lot of that information wasn't included because it was a very small percentage of our overall population. But what that really did for us, and I think we'll talk about it in a minute, is it allowed us to connect a little bit more with our partners and to be able to say there's a need here for us to be able to gather information with schools and to have that conversation with our school systems in the state and in our surveillance area. So we were excited about the partnerships that we did have, and we were certainly grateful for that. And we actually have an opportunity for our 2012 study year to partner with more school systems. So what's unique to Alabama? As I mentioned, we are heavy on the healthcare data sources. We are probably one of the more rural states in terms of our sites, and thinking through what that means in terms of identification, assessment, just some contextual issues I think that we're trying to delve into. And I think it's important to note that so much progress within our state has been made over time, and Anna will talk about that I think sometimes our data are a little bit behind in terms of being able to really reflect that. So we're hopeful that as we move forward, being able to say, all right, we are seeing a decrease in the average age at which a child is identified, et cetera. So those are the important things, and to think through things like our children actually getting in early enough to be assessed and to get plugged into the services that they need. So our next steps, we're going to continue to partner with school systems and other stakeholders. We've been working with the Autism Interagency Council on a variety of activities that I know Anna will talk about, and to continue to look at these systems level characteristics, policy changes that are happening with some of our other partners and our other advocacy organizations, to think about how not only for autism, but also for developmental disabilities as a whole, in terms of how those initiatives fit together and what we can do to bring to light the needs for all of those families. I think certainly is an important part of how we see the data informing the story, not necessarily being the story, but being a part of that and moving forward. So my contact information is there. Be happy to field any questions in terms of the specifics of the data. That was a quick overview, and there's a lot of nuances. And I certainly do want to recognize our wonderful team, Drs. Beverly Mulvihill, Dr. Julie Prescott, Beth Johns, who is our Education and Outreach Coordinator, Eric Lott is our Program Manager, and then we have three fantastic abstractors, Michael Vaughn, Robin Bates, and Ayanna Underwood, and we are very, very grateful for the work that they do and the role that they play in this part of the story in Alabama related to autism. So with that, just a brief note of our cooperative agreement with CDC in terms of how we're funded. And I'm going to pass the slide button to Anna.
Thank you, Martha. And thank you for joining us today. As they had said, my name is Anna McConnell. I'm the State Autism Coordinator with the Alabama Interagency Autism Coordinating Council, and we like to call it the AIACC, or the Autism Council, because that is a mouthful. So to be able to know when I refer to the Autism Council or AIACC, it's the same thing in this presentation. I also work for the Department of Mental Health. They are the lead agency. A number of agency partners that are members of the council. It also includes stakeholders, and I have a list later in the program, but also with the Department of Mental Health, since they're the lead. And then also I had the opportunity to be the ACT Early Ambassador for the CDC's Learn the Signs Act Early program. And so that was being able to spread the message about needing early identification and early intervention services as early as possible for children who have been identified with developmental disabilities and autism. So that's some of the background that we've had. And then also just for purposes of this program, when I say autism, I mean autism spectrum disorder, and it includes, it's autism or ASD, and it includes Asperger's, all the diagnoses that were part of the DSM-4, and now DSM-5 has condensed it to autism spectrum disorder. So just know there's a lot of letters being used, but so that's what those are intended to be. Let's see. That's our next panelist. And so as far as the need, just trying to tell the story of Alabama and where we are as far as autism, as Martha said, the data has been informing the story and isn't necessarily part of the story. And to me, the story is the families. The story is things that they come up saying they need for their loved ones, for themselves, individuals who are self-advocates, and they're the story. That's the whole reason why we have all of these initiatives. And so prior to 2007, just giving you some background on everyone's story, there were a number of grassroots parent groups that had come together and they had voiced lots of needs, and it had been informal voicing. They had come together and made tremendous progress. They put together programs of services for their children, but it was definitely not enough. And the statistics for autism had been steadily increasing. I know you saw some of the statistics that Martha had put up, and you talk about just recently it was 1 in 150, and now it's 1 in 160 and 1 in 68, and before that you talk about in the 90s 1 in 10,000, and so it dramatically increased once we started hitting the 2000s. And up until that point, the last needs assessment had been in 1985 with the Department of Public Health, and that was addressing current needs. But once we hit the 2000s, we needed a lot more information. So that was happening. We also thought about looking at what the infrastructure for autism looked like. Services were scarce, not coordinated, fragmented, lots of issues there, and there was no infrastructure. And so the capacity was poorly matched to the need. You had this tremendous growing need without the capacity, the services, everything to go with it. And so as Martha mentioned, some of the things that we heard through the needs assessment process, especially started in 2007, that went along with some other activities that I'll tell you about, but that's kind of our crucial year for getting things started in Alabama. But one of the things, capacity related, was early detection. We know that from the information that she had provided too, that in 2002 the median age of diagnosis for autistic disorder was 5.5 years old. In 2010 in Alabama it went to 4.5. So we've seen progress, but it's slow. And so it shows the need for what we have. And then for getting a diagnosis is difficult for families. It's in the past 5 years, we've seen tremendous change. However, some healthcare providers didn't provide screening for developmental disabilities or for autism, and so we've seen more of that. And even once they did, if they did receive a positive screener, where would they go for a diagnosis? They may wait for a year or longer, depending on what time we're talking about in Alabama, and where they live, if they're even able to get a diagnosis. Insurance coverage, autism in Alabama prior to 2012 was an exclusionary diagnosis, so it was specifically excluded from any insurance policy. So that means that any behavior therapy, which is one of the primary therapies recommended, would not be covered, and that's still, we'll discuss that more later. But some of the general needs, if a child had GI issues or a basic checkup, if autism was there, it depends if it would be covered. So thankfully things have changed since then, but this is looking back at some of the express needs. Transition services, talking about moving among agencies. So you talk about for young children who may be receiving early intervention services, if they were able to get a diagnosis early and they tried to move from the early intervention system to the school system, that's a transition that's pretty major. And then you move from school system to whatever adult services you might find. There's a lot of needs that go among those transitions. So there was difficulties with that, and even once you get to that point, you talk about the availability of adult services, and it depends if they are able to get, if they need some mental health services for a placement, or if you talk about employment or secondary education. So there are lots of things going on with that, and then talking more about the needs as well. Eligibility requirements, that was a big thing that we heard about from families and from service providers. It depends on the funding agency, and there's a lot of reasons why your eligibility requirements are different. But when you move from age group to age group and the agencies and funders that serve those particular individuals, they don't overlap necessarily. And you probably, thing that we're still working on now is receiving a diagnosis of autism doesn't necessarily mean you get services. It means you meet services based on eligibility requirements. So trying to educate families on that is an eye-opener for what they may receive, and it reflects a fragmented system of care. Talking about access to services and best practices, the Combating Autism Act of 2006 did a lot to encourage research, encourage information to be available, and so that has made a lot of difference in being able to identify and approve applied behavior analysis, ABA, therapy, that there was already research supporting that, but there's more of it now, and then other therapies as well have been able to be looked at and reviewed, peer-reviewed journals, replicated, and even just looking at other journals and doing a meta-analysis has been really helpful to be able to help families and service providers identify best practices and services for those with autism. And then also thinking about training. Training for families and for professionals wasn't readily available. There was a yearly conference, but that may be about it, and that was for families and for professionals. So when you start thinking about specific disciplines and autism-specific therapies, you need more information. And then also thinking about the lifelong nature of autism and the family support and structure. It's not something that goes away necessarily, but you can, with therapy, you can help with coping with stress. You can help with social skills. There's lots of things that benefit, and so getting early intervention, meaning interventions early in childhood, make a big difference and all the way through. But it's also hard for the family, so making sure that they have respite opportunities, which were not necessarily available based on the autism diagnosis, and it depended on where you lived to be able to receive those services. So, and then autism research we had talked about with the Combating Autism Act. So there was a lot of needs, and it's definitely overwhelming. So in 2007 through 2008, we worked on the needs assessment. That coincided with the Alabama Autism Task Force. In 2007, House Joint Resolution 23 created the Autism Task Force, and that was chaired by then Representative, now Senator Cam Ward. And he, along with Lieutenant Governor Folsom, did a lot to be able to bring autism to the forefront. They both have family members who are affected, and so they know some firsthand accounts of what the needs are and what families were saying. And as you look at these things that are major legislation activities in Alabama, know that it's grassroots and parents and organizations that came together with one message made this happen. So I just want to make that as part of the story. It is the activities that they're doing, and that the council is trying to carry on those working on those identified needs. So we had the Autism Task Force that led to the creation of the Alabama Interagency Council, the AIACC, and it became a permanent entity in 2009. And so the task force morphed into and was turned into the council. And at that same time, in 2008, the needs assessment was completed to inform the work of the council moving forward. And then in 2009, what we're focusing more so now is the creation of regional centers, or networks as we're calling them, has been legislated, but funding has not been allocated. So that's the key when we read that. But it's going to be a great opportunity. We have lots of things lined up that I'll be talking to you more about as we move forward. And just so you know, as far as the Interagency Council, we have appointments. I thought it was on the slide, but I don't see it up there necessarily. But some of the stakeholders that are part of the council that participated in the task force are individuals with autism, parents, a number of state agencies that provide services in some form or fashion or funding to those with autism, You have the local UCED or University Centers of Excellence for Developmental Disabilities, advocacy organizations, and then also the Alabama chapter of the AAP. So we are well represented to make sure that we have voice and information from all stakeholders. And then also the charge of the council, so thinking about all of the needs that we've heard and where we've been for the council. And the legislation, the charge is to meet the urgent and substantial need to develop and implement a statewide, it's a lot of words, a statewide, comprehensive, coordinated, multidisciplinary, and interagency system of care for those with autism and their families. So it's a big job. It's a lot to be given, but I definitely think it's manageable. It's something that's needed and that's been very well voiced and articulated by families and individuals on the spectrum. And so when we think about the mission statement, before we had seen the charge, and this is the mission statement, and it's to guide the collaborative effort to facilitate the lifelong system of care and support for autism with families with ASD or associated conditions so they may enjoy a meaningful and successful life. And when we look at that, seeing the overlap, the main information there is the system of care. That's what's needed. That's the information that is so direly needed. And then also just to be able to think about lifelong. It's not confined to when we talk about needing early services and interventions at an early age. It's lifelong. This is a lifelong disorder, and so trying to make sure that we offer appropriate support. Many of you may be familiar with the maternal and child health pyramid of health services. I think it's a popular public health image, and this has been really helpful for me in thinking about a system of care for autism and then also explaining it to other people, because when we think about a system of care, what we end up hearing the most needs are the direct health care services. So the top of the pyramid is what we think of the most. We need the occupational therapy, we need the behavior therapy. These are the things that will help my child. But in order to have those available, there's so many other pieces that need to be in place. And so that's where our focus is, so we actually build an appropriate system of care. And so this is the general version, and I kind of filled in the blanks for autism, just some things that would be more autism specific to get things going. And when we talk about it, we've focused mostly on the infrastructure building, so the base of the pyramid and the population-based services. So that's where most of our attention has gone, knowing that we want to affect the things at the top. And a lot of what we've been focusing lately on are funding issues to be able to support these services, thinking about insurance coverage and also just basic funding for agencies and the services that are available there, and policies. So that's how a lot of the ADDM data has been impacting and informing what we use to try and change policies. It's worked with lawmakers and it's worked along the way, so that's what we're using it for. And so just to be able to know, this is the format. So if it looks like you don't see changes in the specific activities where you don't see the respite, there's movement being made, and we're definitely seeing changes there, but the biggest changes have to start from the bottom and move up, and that's where you'll see most of the information, most of the change and impact for families. Thinking about how we use the ADDM data here in Alabama, as I had mentioned, we used it all along when we had looked at the slide with different dates, talking about the task force and the council and regional networks, to educate lawmakers. So thankfully now, before in 2007, there was a lot of work of saying, what is autism? Have you heard the word? Do you know what it is? Do you know somebody with autism? And more and more legislators know people in their districts who have autism, their families, and they know what the needs are. And so the grassroots organization, the families, the service providers in the area have good relationships with their legislators, and that's been really key. But to provide the anecdotal information and the data of the statistics has really been crucial, because what we would like to do is talk about how that influences funding. So if you think about the number of individuals served and you apply that to Alabama, I mean, just trying to make it more practical for the legislators has really been important for us. And so what we do is we try and demonstrate that need also for funding agencies. just so they see what they're doing. They probably already serve, I know they already serve individuals with autism, but maybe under different diagnoses. So if we had more specific interventions for autism, or they were made eligible for services based on an autism diagnosis, how would that affect you financially? How would it affect the services that you're providing? Would it make things more available? So there's lots of policy implications and ways to improve the system that's already there. And when we talk about a system of care, we're not talking about creating a brand new one. We're using what's there and making it work and adapting it for autism. So that's what we're thinking about. And then also, when we think about using the ADDM data, we talked about the age of diagnosis, trying to make that earlier. And the biggest part of Learn the Signs, Act Early, the message in Alabama that we've been talking about, is when you refer for a screening, when you refer for a diagnosis, refer for intervention at the same time, because that will speed up the process. You have long wait periods for receiving a diagnosis, but because of eligibility issues, it's not going to be based on the diagnosis anyway. So go ahead and refer that child for an intervention immediately. And then also some other policy implications. Using the data, what we want to look for in the future is what policies or procedures contribute to receiving that late diagnosis and intervention. So that's something we're looking for in the future. And then also we had talked some already about service eligibility. How does that play a part in diagnoses? If you're not receiving services based on an autism diagnosis, is that part of why they're not being picked up? Because they're receiving services under something else, but it will come back. As they age, you need a diagnosis to be qualified for certain other services. So we do have fragments and disjointedness that we need to address. And then also thinking about the ADDM data, what's needed to improve the early identification and intervention. Thinking about training, funding, insurance reimbursement, other things that we can use to be able to use the ADDM data to inform what we're doing. And then also, as part of legislation, just so you know what's going on in Alabama, in 2012 we expanded insurance coverage for medium-sized companies. It was there's still more progress to be made, but for applied behavior analysis, that was included in this small expansion. But it also required for board-certified behavior analysts, or BCBAs, to be licensed. Well, there wasn't a licensure mechanism in Alabama, so in this past legislative session, that was created. So we're working on making that available for families, for professionals, so they would be able to be billable, basically. And then also, as part of the 2012 expansion, it wasn't part of legislation, but occurred at the same time, that rather than just having 30 sessions available for OT speech, PT, it expanded to 100. So that's part of saying we are affecting the direct healthcare services, but just not at the same rate that we would like. And then also just briefly about the Autism Council, and the role is to guide the development of system of care. And so that's what we've tried to really focus on, is guiding and not providing, because the system would provide the services, it would provide the activities, and we're guiding its development. When we think about regional networks, the legislation says it would be non-residential resource and training services. So there's lots of different ways that can be interpreted, so that's what we're working on with a strategic plan right now for autism. We're working on updating that plan, and the objective is to move these two activities forward at the same time, so guiding the development of system of care and the regional networks. And then for the strategic plan, these are the you see the 2014 activities. Those are the goal areas that we're focusing on, and they've carried over from the 2011 strategic plan that we're updating, with the addition of a stronger focus on the regional center or network. And really that means getting funding for it and making sure that we have everything in place for its development, and a lot of that's outlined in the legislation. And so this is what we had talked about. The biggest focus right now is cost, trying to make sure we've got that as a major focus as we look for a strategic plan and activities for moving forward. And then we may also refocus some of the committees of the council to align more closely with the goals of the strategic plan, just trying to make sure that we are not wasting time, activity, energy. The people who are on the council are all volunteer their time and energy, and so does everyone else on the committees. And so we appreciate that and want to make sure it's the best system available for families on the spectrum, and it's a slow process. But thankful for the ADDM information that's provided and all the families and the service providers who participate in this. And part of what we've learned over time is that we are similar to a lot of states and very different to a lot of states. And so this is just a broad overview of where we are in Alabama, but we also want to look at other states like South Carolina, and so that's what brought Dr. Charles to us, is some recommendations that South Carolina looks very much like Alabama in a lot of ways, but maybe ahead in some other ones. So Dr. Charles, I think, will be talking more specifically about activities that they have going on. And just quickly, I wanted to make sure that I forgot to put my contact information up, but the AIACC website is www.autism.alabama.gov, and my contact information is available there, and minutes, documents, everything is available, so please feel free to contact me. I will pass it to Dr. Charles. Thank you for joining us, too.
Thank you so much, and it was very interesting. I'm part of the ADDM team in South Carolina, but it was very interesting to hear what's going on in Alabama, and I was kind of comparing back and forth, what we're doing and what y'all are doing, and it's a lot of similarities, and then there are, like you said, there's some differences as well. So, what I'm going to talk about. Let's see. I guess we don't have a title, but that's okay. In South Carolina, we have very similar issue trying to get children diagnosed early so that we can provide the early intensive behavior intervention, or the ABA. We call it EIBI in our state. The issue is that the Part C program, which provides services up to age 36 months, would provide EIBI or ABA for free to parents. However, most of the time the kids didn't get diagnosed until shortly before their 3rd birthday. So then they missed out on getting this very important type of therapy. And just like in Alabama, the wait list for getting this diagnosis in our state is long. Could be up to 6 months or even longer. So again, just like in Alabama, we have a ADDM program in South Carolina. The current age of first concern is before age 3, but the average age of diagnosis is closer to 4.5 to 5 years of age. Again, very similar issues to around the country as well, and all. So we do know that it's very important to get identified very early, before 36 months if possible, so that we can get more intervention in place, get it in place, and get it going very early on. And all. So again, more intervention. The ABA can optimize long-term outcome, reduce lifetime cost of services, improve functional independence. And there's pretty good evidence, I think, now to show that this is true. American Academy of Pediatrics came out with the Autism Toolkit in 2007. And this is for pediatricians and family medicine people and other healthcare providers. And it provided algorithms for developmental screening, for just general developmental screening, and for autism, specific for autism spectrum disorders. The surveillance and screening tools were available for different age groups. And there were some fact sheets for pediatricians and healthcare providers about managing very specific issues for kids with ASD, such as sleep problems, GI problems, eating, a lot of issues surrounding eating and nutrition, and behavioral issues as well. There was also some family information. So the one thing that was really important that they recommended was to use a tool called the MCHAT, or the Modified Checklist for Autism and Toddlers. And this is an autism ASD specific primary or first level screener. It's supposed to be used in general pediatric or family practices at the 18-month checkup and the 24-month checkup. It was also recommended to be used more frequently in high-risk kids for example, kids who were younger siblings of children already diagnosed with an autism spectrum disorder. So the MCHAT was came out and for kind of universal recommendation for screening. You screen, the reason you use it twice at 18 and 24 months is to catch any type of any regression that may occur between those 2 months. It's about 25% of people with autism spectrum disorders have an episode of regression sometime between kind of like 15 and 24 months. The neat thing too is that the MCHAT is free. It's right off the internet. And the whole point of giving the MCHAT was that as soon as, if the screen was positive, you'd refer them immediately for a diagnostic evaluation and then get your intensive early intervention services going. However, as we know, the referral can come very fast, but the actual evaluation may take up to 6 months to get. So long waits for multidisciplinary evaluations in our state, up to 6 months. So there's a delay, again, like noted earlier, initiating these intensive services. So ideally, what we were looking at in South Carolina was to try to develop a system that if we had a positive screen, then we would start the early intervention services regardless of whether we knew the kid actually had an autism spectrum disorder. Then later we would confirm it, we would get the kid on the wait list, we'd start the services, get the kid on the wait list for a diagnostic eval, and go ahead and proceed with services while waiting. Figuring that if the child did not have autism, when he later was evaluated 6 months later, then we really didn't lose anything. In fact, everybody would have gained anyway. So we know that the gold standard diagnostic evaluation is using the Autism Diagnostic Observation Schedule and the Autism Diagnostic Interview Revised. We also do, in our state, we have 3 developmental centers, and we also have a state agency that provides services for people with autism, intellectual disability, and head and spinal cord injuries. And they do autism evaluations as well. So in the 3 developmental centers, we do the ADOS, the ADIR. We usually do it's usually a multidisciplinary assessment with a pediatrician and a clinical psychologist. So they get a pretty extensive history taken, a medical evaluation, and then any other kinds of studies if needed, say an EEG or an MRI, if the history and the physical kind of relays that. So another concern that came up when we were talking about trying to screen kids before 36 months is that can you actually do that? Can you diagnose an ASD at a very young age within the first couple of years of life? And so we looked up. There are some good studies. Rebecca Landa and Mayer in 2006 came up with looking at a large number of children who were at risk. Found that at 6 months, the kids who later received a diagnosis of ASD really didn't look any different around 6 months, but by 14 months, there were some differences in some of the evaluations and all. So they looked like that changes could be seen between 14 and 24 months. And then Zwagenbaum in 2009, they also looked at another group of kids who were at risk for having an ASD, and found that by 12 to 18 months, things were popping up that looked like that would distinguish kids later on from who were not diagnosed with ASD to the kids with autism. Same with Ozanoff in 2010. So it looked like about around 12 months, things were starting to change when you could probably most accurately make a diagnosis. So the challenge, what we discovered, was to try to find a way to evaluate children fairly accurately early on, before 36 months, so we can get them in and get their ABA, or the intensive early intervention, started. So we met with a guy named Zach Warren, who was at Vanderbilt University. He's a clinical psychologist, and he had come up with a program in Tennessee to exactly what we were looking for, was a program to evaluate children quickly and get them into services. Let's see, we wanted to get them in, we wanted to link them up, and we wanted the people who were doing the evaluations to get adequately reimbursed as well. So he started a program with the Tennessee American Academy branch of the American Academy of Pediatrics called Start Ed. And they linked up with the AAP along with Wendy Stone, who developed the tool that I'm going to be talking about called the STAT. And what they did, they met with pediatricians and they trained a group of pediatricians who were interested in doing developmental assessments for children who were at risk for having an ASD by screening positive MCHAT kids with a tool called a second level screener called this screening tool for autism in toddlers, or the STAT. So the MCHAT is a primary level screener, and then the STAT is called a secondary level screener. So the STAT does not give a diagnosis, but it gives it's a more intense type of screening tool than the MCHAT is. So then they got the Part C program in Tennessee to agree to accept the results of the STAT, or the second level screener, to start the early and intensive services while the kid got on a wait list to get the gold standard diagnostic evaluation with the ADOS and the ADIR. So let me talk a little bit about the STAT. It is a 12-item tool. It takes only about 20 minutes to administer. And it was designed for children 24 to 36 months, though you could go down a little bit earlier to 18 months, which fits in well with the MCHATs, since the MCHAT is used at 18 months and 24 months. It has pretty good sensitivity and specificity. Sensitivity 0.32, specificity 0.85, so that looked good. So in South Carolina, what we did, we brought the STAT program into our state, and we started it by when our statewide ACT Early team met in Tennessee in 2008 at the regional ACT Early Summit meeting. On our team, just like kind of the Alabama team here, we have key stakeholders. Various agencies are represented. Our disability agency, the Department of Education. There are some service providers and also some parents of kids with ASD. And we met with a bunch of other ACT Early teams from around the country, and we came up with two plans in for South Carolina. One was a roadmap of services, and the other one was what we called the STAT MD program. So it was we had changed the title a little bit from what Tennessee had, and we called ours STAT MD. This was the training for the STAT MD was funded by the Association of Maternal and Child Health, one of their AMCHIP grants. And we had our first training in June of 2011. And we actually brought Zach Warren in to do the training. We had it in Charleston, South Carolina. And it lasted a day and a half. And we had quite a variety of different people come. We had pediatricians. We had one family medicine provider. And then we had a number of people providers from the state agency that provides services for people with autism spectrum disorders. And in the training, Dr. Warren went over the core features of autism. We actually had the training with the STAT, how to do the interviewing and discussing the results with the parents, and then we had a little section on billing and coding. And the whole point of this was to teach us how to do an evaluation, a nice comprehensive evaluation within an office setting, okay? In a developmental center, like where I work, of course, we have half a day or, a number of hours to do an autism evaluation, but of course that's not practical to do in a private practice. So he taught us how to do this within, say, about an hour or an hour and a half. We did give CME during this training. We had a number of pediatricians, like I said. We had nurse managers of a large practice. We had developmental pediatricians come as well. So an example of how this would work in a private practice is that you would do a medical assessment, just a general medical assessment, rule out any sensory issues, for example, hearing impairment, get the kids get hearing audiology evals, do a neurodevelopmental history, do a physical exam. And then you do a semi-structured social interaction, which is what the STAT is all about, and also kind of note observations in the waiting room and during free play as well. You do a structured interview with the parent, and then do a feedback at the end. In the AAP toolkit, they have a section on actual coding. So this is to encourage pediatricians and family medicine and other healthcare providers to actually do screening, and you can actually get compensated for it. The American Academy of Pediatrics has worked really hard at getting diagnostic codes out there that can be used by healthcare providers. The one we use for screening is the 96110. And this actually is not a huge, big reimbursement, but it actually pays for clinical staff time in order to interpret the tool. And then the developmental testing can actually be used, use the code 96111, and you can use that for the STAT. Let's see. The other thing that was important is that you can use relative value units, or the RVUs, for MDs can be assigned as well. Okay, so what happened in South Carolina? After we had the testing, we had the training, we went to the Part C people and said, can you change your policy from requiring an ADOS diagnosis in order to get your ABA therapy to using the STAT instead, using the second level screener while the child is on the wait list to get the gold standard diagnostic tools using the ADOS. It took a year to get that changed with our Part C group, and which I found very frustrating. I just thought we could just go out and do it, but that's apparently not the way things work. Then, once they got approved, the Part C staff had to be trained, which I also found a little bit frustrating too, because I just wanted to go out and start. And so the actual STAT evaluations did not really start until October 2012. So our state agency that provides services is called the Department of Disabilities and Special Needs. And they're the ones that have taken control over this program. And they had some concerns about some of the people who've been trained to do the STAT, in particular pediatricians and family medicine people, because we are not, in general, most pediatricians are not trained during any of their residency training to do standardized testing, okay? As a developmental pediatrician, of course, I've been trained to do so. So all the developmental pediatricians were okay with that. However, so there was a concern with that. Our DDSN agency also, in order to kind of keep control over who was doing it, you had to go through the training and then get on a list to be a provider. And then after our first two trainings, this is kind of who came up on our list. Most of the people that are providing this tool right now are the autism consultants who work for the state agency DDSN. And they are, of course, trained in using standardized tools. So then what happened? We've so far had 3 trainings. One issue that we had concerns with was who was going to pay for the trainings, because each time we have to bring Dr. Warren in to do the training with us. And our state agency has stepped up to the plate, the DDSN, and they're going to be paying for the trainings from now on, which is great. Again, there was concern with use by physicians who lacked experience administering standardized tools. And so DDSN has allowed us to come up with some extra training about what standardized testing is all about, and really try to make sure we have pediatricians who are really very interested and very committed to doing this and to staying reliable. So again, they have to commit to doing a specific number of stats a year, commit to being retrained, and we felt like, even though I wanted to kind of develop this network of pediatricians around the state, we may not be able to get quite as many in who can commit to that much time, but at least we know that the program is reliable. Okay, so we started with getting kids who failed the STAT, and that started in October 2012. The first year we had 204 kids approved for EIBI, 104 of them from a failed STAT. The others are from the ADDS. And then 3 of the kids who received who EIBI due to a failed STAT got an ADDS later on and were found not to have autism. And that indicates, I think, that the STAT has a pretty good positive predictive value for that population, 97%. So here's a nice little table that shows that from 2010 to 2013, when we actually started in 2012, but the number of kids getting services based on failing the STAT is in red. And by the end of 2013, almost half the kids getting EIBI were getting it due to a failed STAT. So that shows how many got in more quickly than waiting the 6 months to get an ADDS. Okay, so probably this is kind of where the lessons learned come up. There was some confusion early on about trying to getting the word out to the EIs about when to make referrals for STATs. We were getting kids who the EIs were administering the MCHAT before 18 months and then having the kid fail it because it was not designed for children before 18 months, and then referring kids in for STATs. And so that got a little confusion there. We did solve the second one, which was having ongoing source of funding for training. We have developed, or in the process of develop the extra training for the physicians on using standardized tools and arranging follow-up to maintain reliability. There's some concern, even though we were, in order to encourage pediatricians to do this training and to do the STATs, they were charging for it, which of course is what the whole point of having the codes and everything. But they could also, the families could get this done for free through our state agency. So there's a little conflict there we're working on. Probably the last issue was the biggest one, and that is in South Carolina, the Part C program was reimbursing the EIBI providers at a certain rate, and once they turn 36 months, we have a Medicaid waiver program in South Carolina to provide ABA therapy. And that Medicaid waiver was reimbursing the providers at a higher rate than the Part C program. And so we were so proud of ourselves getting all these children out there and getting eligible for EIBI, but there were no ABA providers to serve them because they couldn't afford to. They basically could not afford to be reimbursed at the much lower rate that the Part C program was doing. So this spring, one of the parents, actually, who's also kind of a lobbyist on the Act Early team, and I went to Columbia and visited the legislators who are involved in the committees that are involved with this type of funding, and showed them the differences. And now the Part C program will now begin, starting July 1st, to begin to reimburse at the same rate as the Medicaid waiver program does after 36 months. So that was a huge issue that's been going on the past 2 years, and especially people in children in rural areas could not. I mean, there are very few people out there to provide ABA services in the first place, and then having. The providers were telling the parents they needed to help pay and things like that. So it became very difficult. But now that has looks like no longer an issue starting July 1st. And I think that's it for my presentation. Yeah. So I understand we have some questions, perhaps.
I don't have any yet, but I would like to know from our UAB person, are you having any difficulty getting school records? I mean, what school records are you looking at? Because I know working here in the health department with immunization and the FERPA rules, it is terrible to even look at a blue slip. So I can only imagine.
Right. Well, and because we have the partnership, as I mentioned early on, with ADPH, so we're actually a bona fide agent, so this falls under that umbrella of surveillance. But the way that the state interprets FERPA limits our capability. We have the support of the Department of Education, and they have been gracious, wonderful partners, and have sent out letters to all the school systems in our surveillance area or across the state and have said, you know, this, we know about this, we like the project, but they have to make a decision. So part of our challenge has been in Alabama, this is not the case for other states, we've had to go school system by school system and have had to have those conversations with superintendents and with the attorneys at the level. And we've had some success, but that was, if you noticed our timeline, 2002 to 2000, I guess it was probably 2009 before we got kind of our first, before our 2010 and 2012 surveillance year started. So that's been a challenge, but I think as we've been able to partner with some of these kind of infrastructure building issues, we've been able to have more conversations. So, and I think it's also from the parents' perspective, of being mindful that, you know, we've had some conversations of, gosh, we don't know that our parents would love having you look at the records. So, you know, but trying to navigate that. So certainly that's been a challenge. But I think y'all probably have had a different experience.
We were very fortunate that we were able to have a cooperative, have an agreement with our State Department of Education from the very beginning. And probably the main reason is the person who was the Director of Special Ed Services, or the Office of Exceptional Children for the entire state, had an adult child with an autism spectrum disorder. So when we went in there, it was a, you know, we got it all. We were a bona fide agent representing our Department of Health Department, and we were able to come up with an agreement with the State Department of Education that was all okayed by the attorneys, and we've been able to maintain that relationship since 2000. And we were very, very fortunate. Again, it's kind of a small state situation.
And I think the way that the education systems are set up across the states where there are ADDM sites varies a little bit, because I think for, you know, there's data capacity issues that I think that can be challenging in terms of actually getting the data.
Yeah,
period.
there was
a
lot of the data is on paper, and you know, in trailers out in that get flooded, and they run in the trailers, trying to get warehouses and stuff like that. I think many of the counties now are on computerized records now, but it was tough in the early years.
Yeah, so we were thrilled that, and so for us that was a huge hurdle in terms of even though, and if you look at the report, it's not in there, but it's still in there, and we were grateful for the school systems that we were able to partner with, and I think that's growing, hopefully. So.
Okay. And really, we'd like to remind people to call in. I'm sure the number's down at the bottom of the screen. I don't see one, but I'm sure it is. Or email us here. Yeah, I have a nephew that has Asperger's, and he is both a joy and a frustration. But I will say that my sister is a nurse as well, and as soon as he could crawl, he was lining stuff up, and we both recognized that this is something that's wrong. So he was between 12 and 15 months old, lining stuff up, and you would go in every room. There were books lined up. He has enough track from Thomas the Train to line between here and Tallahassee, Florida, because it's a straight line, and he loves straight lines. And you get to talking to people who have children who have these conditions, and it's very frustrating for the parents. But my sister and my brother-in-law are exceptional, but it's also it's a joy as well as a frustration.
Dr. Charles, I was really intrigued with the stat and found that to seem like a really reasonable and responsive effort. I think you had stuff up there, but I'm not quite remembering.
Right.
How many people now in the state of South Carolina can perform that?
I don't know exactly how many are on that reliable list right now. The one thing that was that was kind of neat, what we were able to get at our last training, it occurred, I was giving a lecture about autism, and some speech language pathologists were attending, and it kind of we were talking about this stat afterwards and our effort, And it kind of occurred to all of us at the same time that it would make a whole lot of sense to have speech pathologists trained as well. Because they're often the first, a lot of times pediatricians will refer to a speech pathologist even before referring to the Part C program. So in our state, that's called BabyNet. And so a lot of times speech people see kids, and they will make the referrals to BabyNet, especially if pediatricians are not really part of the loop. So in our last training, we had a number of speech pathologists added, and what was nice, too, is that their speech pathologists, of course, are all trained in using standardized tools, because that's what they do. So that just eased that right in very easily and all. So I'm not sure what the most current numbers are, but they're probably at least 25 or 30 people.
And what types of professionals?
Most of them, there are not very many pediatricians that I've been trained that are doing this on a regular basis. There are probably just a couple.
Is that maybe not lack of interest, but maybe just lack of time? Probably.
The ones that are doing it are people. There is one retired pediatrician who is doing a lot of developmental work just out of interest on his part, and a couple of pediatricians around the state who just in their own little cities have become kind of the developmental practice, and where there a lot of other pediatricians are sending kids to them, and they've started doing the training. I think our whole point was to set up kind of these regional pediatricians that other pediatricians would send kids to them when they have failed the MCHAT, and it didn't quite turn out that way. But there are a lot of providers out there doing the STAT, and we've had a huge number of children referred and starting therapy because of it. So I think eventually we will work out more pediatricians that just won't be as big a program as I thought it would be, and that's fine.
Thank you, Dr. Charles. I think we have a call.
Yeah, we have a call from here in Alabama. Go ahead, caller.
Yes, I do have a question for professionals in Alabama. The question would be, what services are available, or are there any in place for those that age out of early intervention, any kind of specialized services or intensive services once they do age out of early intervention?
And is that for those who would be receiving services with early intervention, and feel free to chime in as well, there's a lot of private groups that provide services, but then there's also Help Me Grow is located in Central Alabama, and that can help with referrals and trying to make sure follow-up and that you find some of those providers. And then also through the school system, as long as it's impacting their education, you can receive some of those services also through the education system, and there's speech and OT opportunities. But as far as mandated services, when you talk about that, you talk about through early intervention and through the school system, and then beyond that, it's more based on eligibility rather than requiring services based on certain eligibility. So I hope that answers the question, but it's primarily that I'm familiar with private providers. So there definitely are, and we're hoping to expand. I was talking about some of the behavior therapy, expand opportunities, because it can be really, really helpful for a lot of these, but there's just not necessarily insurance coverage for it, or that it's very minimal. So, so that would be what my response would be, but there may be other opportunities.
Well, I was just going to ask, to be able to navigate that, would it be Autism Society that might be a good connection?
Yeah, so thank you. The Autism Society of Alabama does a lot of information and referral activities, and their contact is 877-4-AUTISM, and their website is autism-alabama.org. And there's parents who are available online. There's support groups, networking groups, and often I found that depending on what part of the state, we may think we know providers, but the parents really know a lot more of what provider does what. So Autism Society has good connections to parents as well to be able to connect individuals. And then also on their website, there's a resource directory. We're in the process of updating it and making sure that it's able to be updated electronically, because it's just difficult to go in and manually make sure it's all up to date. But I would definitely suggest contacting the Autism Society. They would have a lot of information.
Okay, we've got an email here. This is for Dr. Charles. Have you begun to, or do you have any plans to look at school-age outcomes for the group of children who got the services earlier, and as opposed to those that didn't, or the extensive services? Have y'all done any outcomes?
Well, not yet, mostly because they really only, the year 2013 is probably the year that most of them, but probably we will. The BabyNet has a pretty extensive tracking program, and so I'm sure that once we get a couple of years under our belt, we will probably take a look and see where those kids are compared to the kids who didn't get the services.
And somebody had asked if the slides are available. Those are available at our website. So if you need the slides, please go there, and you'll have to register to get them, but they are available. Another email that says respite care was mentioned. Explain what respite care is, and are there any places in Alabama that you can get respite for parents?
I'm going to get that one. Respite care is getting a break for parents. So you can talk about it for any kind of caregiving situation, and it's not just babysitting. It is, that's oftentimes what it's confused with, and it's quite similar, but a lot of times if you have someone with special needs, anything that needs, so if you're talking about older adults who may have Alzheimer's, or children who have severe physical needs, and it's really hard to find a caregiver. You can't just get the babysitting list and get the high schooler down the street to be able to come and care for a child. And 24-hour care is a lot of work, and so even just to be able to go to the grocery store, to go to a movie, and just have time for parents, especially when, for us, what we talk about are for young children and even adults. So because depending on the nature of how someone's affected by autism, they may still need all that supervision from their parents. So that way you have healthy relationships among the parents and even other siblings, to be able to focus on them as well. And it is healthy and encouraged to be able to take a step away. Just like parents need a night out to go to the movies together and enjoy time without having a child with them, that's what respite is, but it's just a little more intensive, and that's kind of how I'd like to explain it. There is the Alabama Respite Resource Network, and Linda Lamberth is the contact there. I would recommend contacting her. She knows a lot about the different grants that are available per county and different programs. And I feel like it's REST ALA is something, but you should be able to Google Alabama Respite Resource Network and be able to find that information. And give her a call, and they have other staff available through the state that would be able to provide appropriate referrals for respite.
Okay, so I don't have any other calls. Do y'all have anything in conclusion that you'd like to say while we're waiting to see if anybody else calls or emails in?
I had a question for you about Anna talked about sort of some of the legislative activities that we've had in the regional network, or that are being worked on or have evolved over time with the regional centers that are in place, ready to go, but there's no money, which is a challenge. But hearing you talk about the developmental centers and the state agency, just curious sort of how did that development, what was that?
Well, we have 3 developmental evaluation centers, okay, and they're located in the 3 larger cities, Charleston, South Carolina, Columbia, and Greenville. Charleston and Columbia are both located in the School of Medicine. So the Medical University of South Carolina in Charleston, USC School of Medicine in Columbia, and in Greenville Hospital also has a pediatric residency program. So it's located there. So we just kind of all got on board, and we all function in a fairly similar way. I think the reason they call them the DECs, Developmental Evaluation Centers, all got on board was by uniting together and contracting with Medicaid for adequate reimbursement for our services. And so we have what's called the DEC contract with our Medicaid. And that's always kind of an ongoing legislative effort with our specific lobbyists to maintain that so we can get paid. And then the Department of Disabilities and Special Needs is a state agency that had been part of Department of Mental Health many years ago. And then they split off, and as I said, they have 3 branches: autism, intellectual disability, and head and spinal cord injury. And they contract with what are called disability boards in each county. And the county disability boards provide service coordination. And they also, they provide service coordination and may, help people get respite, and sometimes they have funding for camps and things like that. Generally, there's not a whole lot of money associated with it, but everybody tries. And then the Part C program, of course, is pretty separate from that, But probably recently we had the Medicaid waiver, what they call the PDD waiver, which pays for ABA services, and we also have legislation passed to have insurance companies pay for ABA as well, for state insurance companies, and that's called, in our state, it's called Ryan's Law, named after Ryan.
And that's definitely a difference in Alabama as well. We had, we're hoping to work towards that, but the legislation that was passed in Alabama was targeted for 2012, was an optional policy for medium-sized companies, private companies. So it does not affect state employees, teachers, that group. Larger companies are usually governed by federal regulations. ERISA laws is what it's called, and so it's up to each of those ERISA employers to determine if they would provide autism coverage or not. And thankfully, some of the large employers here do. Southern Company was the most recent one that I had heard of. So Alabama Power is a big employer here in Alabama, so that means people who work for Alabama Power can receive services for their child, autism services, and it's covered under insurance. So that was a big deal, and we were excited to hear about that. Still a lot of work to do, though.
Thanks to all of you. This has been a wonderful program. I'm not very versed in autism, so I've just learned a wealth of information. I can't imagine that anyone didn't come away with lots of good stuff.
Thank you.
Thanks to all of you for your efforts.